Welcome everyone to our live Lung Healthy Living Workshop. We have a pulmonologist and lung health navigator who will talk about lung disease, changes in screenings, and insurance allowances. Then our tobacco treatment specialist will help those who have given thought to quitting smoking. Now when you're thinking about avoiding cancer, maybe you get a mammogram or a colonoscopy or maybe a pap smear, and those are all smart. But did you know that lung cancer is the #1 cancer killer for both men and women? So you probably should be getting a lung screening as well. Why aren't you? Maybe you just don't know that much about it. That's where we're stepping in to help you understand how easy it is. Thank you so much for joining us. Now, with the help of our great partners at Mid-Michigan Now, our lung experts are going to answer your questions live today. You can send in your questions anytime by texting, not calling, texting to 248-935-2562. You can also submit questions on Facebook or YouTube. We start with Lung Health Navigator Kevin Reynolds, who has been a registered respiratory therapist for 25 years. He's also a certified pulmonary function technologist. As Lung Health Navigator, COPD Navigator, Kevin coordinates lung screenings and our early detection program, and he is great to work with. Kevin?
Hi, so my name is Kevin Reynolds. I am the Lung Health Navigator here at Early Medical Center. I want to thank you for having me here today. I want to talk about our early detection of lung cancer program. But before I do that, I want to start talking a little bit about lung cancer. Lung cancer is the leading cause of death in all cancers, and it takes more lives annually than breast, prostate, and colorectal cancer combined. It's only detected early, less than 23% of the time here in the U.S., and like any cancer, early detection often allows for higher likelihood of successful treatment. However, early detection rates are increasing. Nationally, as of 2020, early diagnosis rates have increased 33% over the past 5 years. Some of the things that have felt to contribute to this are improved technology in the lung world, better standardized, improved reading with more consciousness being put on early detection of lung nodules. Lung cancer screening programs were started throughout the United States, and smoking rates have gone down, slowly decreasing. So we opened our Hurley Comprehensive Lung Program in 2016. We started it. We opened our Hurley Lung Center. We started the position of a Lung Health Navigator. We started tracking incidental lung nodules in our at our hospital, and we started our lung low-dose CT lung screening program. So the Hurley Lung Center, it's dedicated to the prevention, early detection, and treatment of diseases of the lung. We have a team of board-certified multidisciplinary physicians who work together to diagnose and treat lung disease, including lung cancer. We have a dedicated procedure room utilizing anesthesia for our interventional pulmonologists to do the procedures, and we have a dedicated team with respiratory therapists and an RN who are specifically trained in those procedures. Some of the other things we do lots of diagnostic testing, but we do complete pulmonary function testing, we do cardiopulmonary stress testing, and we incorporate, as you can see in this video, the latest in technology with some of our lung biopsy procedures. The Lung Health Navigator tracks, communicates, educates, and reminds both patients and providers of lung nodule findings on images done at our medical center. Coordinates care when needed between patients and provider, helping them with continuum of care that ensures follow-up happens. And I coordinate the lung screening program as well. Incidental lung nodule tracking. It's important to note that most cancers are caught incidentally or unintentionally. Hurley does 48,000 chest images annually. So what happens if a lung nodule is detected? They'll get told at discharge. Most of the time this does occur in the ER. Our physicians are very good about letting their patients know there's a finding that requires follow-up, get a hold of their doctor. However, these can fall through the cracks at times. So I'm a secondary backup. What I do is I send an alert, a lung nodule alert, to their primary care provider, and then I'll send a future alert when that recommended follow-up is due. If a patient does not have a provider, I'll call them and talk with them about setting up a provider for them so this gets followed up on. And it's important to also know, Hurley being a level 1 trauma center, we get patients from all over the side of the state. And so they have out-of-area providers that would never know in a lot of cases about their patients having some findings. So what I do is once they're discharged, sometimes after a lengthy extended stay here, I get a hold of their physician, send them a report of their findings, and offer assistance if there's anything else they need regarding their reports or questions. And then I'll also call the patient at times if I'm not sure who that provider is. We'll contact them directly as well. Lung screening with low-dose CT. It's a less than 60-second CAT scan that could save your life. It's done when there are absolutely no symptoms. It's recommended in the high-risk smoking population. It's done annually. And recommendations may require further scans in between screenings or further testing if something is found. You must have a shared decision-making discussion with your physician or provider, and once that happens, they would send an order and we take it from there. Lung screening versus other cancer screenings. The lung screening rates in 2015 for breast was 50%, prostate 35%, and colorectal cancer 63%. In 2020, fewer than 6% of eligible population in the U.S. received lung screening. Why is that important? Early diagnosis can be achieved up to 85% of the time in screen-detected lung cancers. Among those early stage cancers, the cure rate approaches 80%. So if everyone currently eligible here in the United States were screened, close to 48,000 lives would be saved. Nationally, like I said, less than 6% of people eligible for lung screening are currently getting it. However, Michigan is a little bit above average. Michigan has more of a closer rate to 8 to 13% screening rate, so we are doing better than some states in the nation. Now, just to clarify, there has been some changes in lung screening in regards to coverage by insurances. 2015, the initial recommendations came down. They have just recently updated that in March of this year. So there's current confusion. Sometimes I just wanted to clarify, if you see different screening criteria, it's because there are some updates being made, and insurances within the next year should be starting to cover with these new recommendations. As you can see on the left side of this screen, current guidelines, and on the right, the newly recommended guidelines. What I would suggest doing is call your insurance to see if they are covering. If you're eligible under these new recommendations, call your insurance, contact your doctor, still have and request that you get screened for lung cancer. And even if your insurance is not covering that yet, what I will do in our program, I'll put you on a list, and I will notify you when I know if your insurance starts to cover that. Some insurances require an authorization prior to getting this, and some do not. If you have any questions, you can always call me directly, and I'd be glad to help and answer your questions. And that is all I have for today. I want to thank you for allowing me to be here, and I want to thank you for being here, and I look forward to answering your questions.
Thanks, Kevin. Kevin, we'll take your questions right after Dr. Parikh's presentation, and you can text me your questions to 248-935-2562. You can also submit questions on Facebook or YouTube. Now, Dr. Niraj Parikh is board certified in internal medicine, sleep medicine, pulmonary medicine, and critical care medicine. He's had fellowships at Henry Ford Hospital, Detroit, and is currently a clinical assistant professor at Michigan State University. We are happy to be able to bring him to you today as an expert on lung health. Dr. Parikh?
Hi, thank you for having me. All right, thank you for the introduction. Thanks, Kevin, for starting us off here. Again, my name is Dr. Parikh. I work with Pulmonary Associates. We're going to continue this conversation on lung cancer screening. So the first question is, why do we do this test? Well, as Kevin mentioned, clinical outcomes are much better if we do this test early, or we detect cancer early. So the purpose is to try to detect it before it becomes a problem, before patients have symptoms, because most patients don't know early on that they actually have lung cancer. And so that's why we use the term screening. So we've determined that there is a high-risk population, and they can benefit from low-dose CAT scans. And by doing these low-dose CAT scans or CT scans, they're the same term, we can screen patients and identify it early, hoping for the best clinical outcomes. So who is eligible for this? Kevin kind of outlined some guidelines for this, but the U.S. Preventive Task Force has recommended patients aged between 55 and 80 who are currently smoking or who have quit within the last 15 years and have at least a 30-pack year history of smoking. Now, let's talk about that. A 30-pack year history of smoking is, for example, 15 years of smoking, 2 packs a day. That would equal 30-pack year history, or maybe a patient is smoking 1 pack a day for 30 years. That would also equate to a 30-pack year history. So as long as patients fulfill the above-mentioned criteria, they are considered high risk and they would be eligible for lung cancer screening. So what does this test consist of? Well, as the term goes, low-dose CT scans, they are essentially a CT scan with less radiation. The process is done just like any other CAT scan, in which you'd lie on a table, you hold your breath, you go in the donut, you come out the donut, you're done. It's non-invasive, it's painless. This can be done at Hurley Medical Center. It's a very quick test. Once the test is done, your doctor gets the results. So let's talk a moment about what a CAT scan is. When we talk about CAT scans of the chest, it's like taking a cucumber, dicing it up, and then looking at each slice individually. When we look at a CAT scan of the chest, what we're looking at are slices going this way of your chest. And by doing that, we can identify if there is an area of interest. Let's look at this CAT scan picture that we have up on the slides here. At the top of the screen where it says example of the results, that's the front of the chest. The bottom of the screen is the back. And when you look at it, there's 2 large black areas. Those are the lung fields. And there's an area on, let's say, to the right of your screen that looks abnormal. And that is an area of interest. As a physician, we would call that a lung nodule. And in particular, we'd call that a spiculated lung nodule, and that is worrisome for lung cancer. So those are the types of lesions that we're looking for, and if we can identify it early, we can intervene on it. So typically, after you do this type of CT chest or a CAT scan, your results would be read by a radiologist. You would go to your doctor would discuss the results with you, and together you devise a game plan. So if that test comes back negative, well, congratulations, we're done. In which case, then you would continue with annual low-dose CAT scans. It's just done once a year. You'd continue with this until the age of 80, because that's the current recommendations. Now, some insurances have varied from that, but that is the current recommendations. And if you've quit smoking for more than 15 years, at that point, we would stop. If, however, you have a positive test, the first thing you have to remember is don't panic. That's the worst thing you can do for yourself, and it's also difficult on your healthcare provider to provide answers without sitting down with you and going over your results together. So the first thing, as I said, don't panic. And the reason I'm saying don't panic is when we looked at the National Lung Screening Trial that was used for the initial approval of this test, 96% of lung nodules did not lead to a diagnosis of lung cancer. What is most important when we're talking about lung cancer screening and spots on the lung or nodules on the lung is that size really matters. If it's a smaller spot, your doctor might talk about doing serial CAT scans. Serial CAT scans can be done at 3 or 6 month intervals according to society guidelines. We can watch and see if it's growing, if it's changing in architecture, and then determine what to do next. If it's a larger spot on your lung, then we might talk about doing a PET scan. So a PET scan is very similar to a CAT scan. It's done in a similar method. However, it's given with a special dye. Now this special dye is picked up by active cancer cells, and it gives you an image like we have on the screen here. That helps us identify the nodule. If you look at that picture down there, you can see it's very similar to that CAT scan of the chest that I showed you earlier, but there's an area that's lit up and has a nice arrow on it. Well, that area has been picking up the special dye, and that is suggestive of active cancer cells. Not only are we looking for that area to light up, but we're checking to see if the middle of the chest lights up, because a spot that's on somewhere in the lung or lung cancer would spread typically first to the lymph nodes in the middle of the chest. And when it spreads there, those tend to light up on our PET scan. It can also help us see if that cancer spreads somewhere else in the body, and that would help us devise a future plan. Now, when it comes to spreading of those cancer cells to the middle of the chest, that also helps us determine what to do next, because the next step is typically to do a biopsy. Now, a biopsy is a small sample of the tissue that we're worried about sent to the lab to see if it has active cancer cells. So all of the tests that we talked about thus far are suggestive of cancer, but we really need a biopsy to determine if this truly is cancer, and we look at that under the microscope, and a pathologist would do that and provide us a report. So one of the ways that we can get a biopsy is to do it with CT guided. So a CT guided biopsy would be done by an interventional radiologist. This is a day procedure. We would schedule it once we determine that that's the best way to get a biopsy. Once it's scheduled, you would come for your procedure that day. They would numb you up locally. They would put you under the CAT scanner. As I said, an interventional radiologist would do this procedure, would poke a small needle into that lesion, get a biopsy, likely watch you for another hour or two after your procedure, and then talk about going home. As your physicians, we would get the result about a week later, and we would sit down and discuss it and see what needs to be done next. Another way we can do the biopsy is through bronchoscopy. Now, in this situation, the bronchoscopy would typically be done as a day procedure also. We would get you to come to the hospital, we'd put a tube down your throat and get you completely out, like most surgeries, so you don't feel any pain or discomfort. While we're doing the procedure, we would take a small camera, go down that tube into your lungs, take a look at the airfields. Once we've looked at all the airways, we would identify those lymph nodes in the middle, and if they're enlarged, we would focus on doing some biopsies. Once we're done with the biopsies, we take our camera out, we take the tube out, you'd wake up, and shortly thereafter you talk about going home. Again, it's a day procedure. You would need someone to drive you home after the procedure, but you'd follow up in a week for the results. Another way we can do it is using navigational bronchoscopy. Now, navigational bronchoscopy is used when there's a spot that's a little bit further down into the lung field and we can't easily access it. So we use advanced technology, which is very similar to a GPS, to make a route all the way down to that spot, and then once our scope can go as far as we can, then we use this technology to get out all the way to that spot. We do our biopsies. Again, this procedure is done as a day procedure. We'd put a tube down your throat, make sure you're completely out for this procedure. Once we do our biopsies, we come out, we take the tube out, you wake up, you go home the same day. This allows us to do all of our biopsies safely so we can come to a conclusion as to what the problem is and get you on the right treatment track. So when we talk about treatment, if we identify these spots early, some patients are an actual candidate for surgery, in which case we would talk about cutting that portion of the lung out. By doing that, we are aiming for a curative intent. Now, when we talk about lung cancer or any cancers, we don't usually talk about cures. But this is one of the instances that we can talk about cures because we can potentially remove an early spot without any problems. You might have a cancer doctor involved in your care because they might talk about doing some chemotherapy after that. In addition, some cancers are not something that we can cut out, or it might be caught at a later stage, in which case they would talk about chemotherapy and radiation, and we'd have a cancer doctor involved in your care that would help you with that. I know that's a lot. It's not easy to navigate through this, but rest assured that my colleagues and I, as part of Pulmonary Associates, are trained in all of these procedures that I just mentioned. We do all of them at Hurley Medical Center. Hurley Medical Center has the resources to do all these above-mentioned procedures. They have all the technology. They have trained professionals to assist us to do all of this, and they have the resources, and they're ready and willing to help out. In addition, we have the only lung navigator in the area that's ready and willing to answer all your questions, that can navigate you through this process, because it can be a bumpy road. Sometimes it's just reiterating exactly what we talked about, helping you through the process, helping you navigate through some of the insurance bumps that might come on the road. So Kevin is a very useful resource, and he helps us throughout this entire process. Now, if you have any questions, Kevin can answer it. But in the meantime, we can answer some questions right now.
Okay, great, thanks. We do want to thank our great partners at Mid-Michigan Now for making the presentation possible today. Both of our presenters are going to answer your questions live. You can still get them in by texting 248-935-2562 or submitting on Facebook or YouTube if you are watching there. And we are getting some questions in. Let's see. Scott says, I am coughing a lot. Is this due to asthma or GERD? Sounds like either he probably wants to get it checked out, right?
I think you should talk to your doctor about that. You know, there are some tests that we can do looking to see which is the problem. There are treatment for both, for GERD or GERD or asthma, and we can put you on those types of treatments to determine what helped you and how to get better. If you are coughing a lot, I recommend you make an appointment with a lung doctor. There's no point in suffering. We can get to the bottom of this and get you feeling better soon.
I'm not sure if you guys will know the exact insurances, but someone is asking if you take Aetna or TRICARE for life. Mary wanted to know that.
We do. We do take all insurances at our clinic. Feel free to call my clinic. You can always discuss it with my front staff. They have, we work with numerous patients right across the state. They are well acquainted with all insurances and they can guide you what we cover and what we don't, but typically we take all insurances.
And Kevin, I think that's one of the benefits of Hurley having a lung navigator is that normally people won't know where to start or who to call, or they try and call an office and ask insurance questions, but they can call you directly and find this stuff out, and it's so much easier.
Yeah, the last thing I want you to do is to have questions and not have anywhere to go or nowhere to turn in regards to your lung health. I'm always available. That's why I'm here. You can call me directly, but as far as insurances go, yes, we have the resources to check into specifically whether or not your insurance will cover certain tests. So.
Margarita says, given the number of factory workers in the Flint area and history of poor air quality, are there programs available to patients to obtain lung cancer screenings if they don't meet the recommended screening criteria?
That would be a conversation with your lung doctor or even your primary care doctor. The reason is currently this program only covers cigarette smoking. There are other high-risk individuals that are smoking a pipe or a cigar, or, as you mentioned, factory workers that are exposed to numerous chemicals. So it is worth sitting down with your doctor, discussing it, and determining what to do next. Because you are correct, those patients are considered high risk.
How long does a screening take?
The screening takes moments. It's, as I said, it's done by a CAT scan. You lie on a table, you hold your breath, you go in the donut, you come out the donut, you're done.
And Kevin, like if somebody contacts you, how long of a process is it before their first contact to when they can actually get screened?
Yeah, so the first thing we need you to do is, like I said, go to your doctor, obtain an order. You need to have that shared decision-making visit where you are fully informed of lung screening. And once that happens, they would send an order, and we would get going from there with it. If your insurance does require an authorization for this test, sometimes insurances do take 1 to 2 weeks before they give that authorization. And then once we get the authorization, we have an order, we'll get you scheduled. So I'd say 1 to 2 weeks.
This person says, I'm concerned about radiation in the screening.
That is a concern. That is a known concern. That's why we do low-dose CAT scans to reduce the radiation. It's about 1/7 to 1/8 of a regular CAT scan, so that does reduce the amount of radiation that you're exposed to.
Dr. Parikh, you did mention, that people could get screened annually. They did it until they're 80 years old. Is there a minimum age?
Right. It's 55 to 80. That's the current recommendation. Just like Kevin mentioned, however, they are in the process of modifying those recommendations. So in the future, those dates or those age ranges may change.
Is lung cancer hereditary?
So there are some suggestions about that and discussions about that, but we do see it more in high-risk individuals that have smoked or have some sort of chemical exposure. And so if you do have family history, it is worth talking to your doctor about it.
Okay, it looks like that's all the questions that we have. Thank you guys so much. I appreciate it. We're now going to move on to the portion of our workshop on smoking cessation, and Danielle Campbell will answer questions on this live. If you have anything you'd like to ask her, text to 248-935-2562, or you can submit on Facebook or YouTube. Now, as a community wellness manager, Danielle coordinates services for patients and population health within the community. She is a tobacco treatment specialist, certified lactation consultant, diabetes prevention lifestyle coach, and certified personal trainer. Danielle has a BS in health science from Grand Valley State University and a master's in public health from Michigan State University. So basically, there's nothing she doesn't do, right?
Thank you.
Danielle?
Hi, I am Danielle Campbell. Once again, I'm the Community Wellness Manager here at Hurley. I love my job. I love working in the community with people and helping them with any issues that they may have. Today I'm going to talk with you about prevention. So hearing all this stuff about lung cancer, you wonder, what can I do to prevent having this trouble? And one of the best things you can do is prevent it by not smoking. It doesn't matter how long you've smoked. There are benefits to quitting. You can see on the slides here that if you have been a short-term smoker, a year or less, 5 years or less, even if you choose to quit today, you will start to see some of the health benefits of quitting, such as your heart rate begins to drop to a normal level. Your carbon monoxide levels will begin to drop down to normal. If you've been a longer-term smoker, years, sometimes people have smoked their whole life, you're going to start to see some of the bigger benefits that are coming through with your health. You'll notice that your risks of various cancers decrease after 5 to 10 years. You're going to notice that your heart attack and your stroke risk are going to decrease as well. There's no bad time to quit. And so if that's something you're interested in doing, just keep in mind those benefits and always focus on the positive as you continue through your quitting journey. Now, even though there are benefits, it is extremely difficult to quit. Smoking is a very addictive substance. The nicotine is extremely addictive to your physical health. You will also see that there are mental and habitual things that are difficult to make it quit. Going back to the physical part, if you do smoke, really consider using what they call nicotine replacement therapy. That is also known as NRT. So think about that like the patch, the gum, there's lozenges, there's a nasal spray, there's an inhaler. A lot of different options that you can choose, some of which are over the counter, some of which are not. But what they do is they help to provide you some of the nicotine as you continue to quit, that will kind of take the edge off and relieve a lot of those physical symptoms as you are trying to push through the journey of the mental, the habitual, the emotional part of quitting as well. There's no bad product to try. There are some that may be recommended over others depending on what your specific situation is. They might recommend the patch to somebody who might have tooth or gum issues that can't necessarily use the gum or the lozenge. They might recommend the inhaler to somebody who vapes. And so there's a lot of different choices that are available, and there's no specific one that may work better for one person over another. There are also other medications that you can get prescriptions for that are another great option. And so there is really no limit to what you can do to help ease some of those physical burdens of the addiction. The mental part is also very difficult as well, but not impossible. So think about some of the habits you have that might be surrounded with your smoking behaviors. You might smoke in the car all the time. So now every time you get in the car, it just kind of triggers something in your head where you're like, well, I'm driving along and now I would like to smoke. Breaking that habit is extremely difficult, but it's not impossible. And so do keep in mind that breaking those habitual habits become easier when you relieve the physical symptoms, but it is very difficult to do, and it's not something that you should have to tackle alone. The social aspects of your addiction are a little bit different. Sometimes people live with smokers. Other times they might take smoke breaks at work. They smoke while they drink. Keeping in mind that that is something that is also difficult, not impossible. Navigating through all of these things together can be so much better with counseling and help. You don't have to do it alone. This is not something that is completely your responsibility. You can have other people there to help you as well. The Michigan Tobacco Quit Line is one of the most useful resources that we have available locally. And so I would really suggest everybody either reach out. You can do this with your fingertips on the computer, or you could also call them. 1-800-QUIT-NOW is one of the easiest ways to get a hold of them. It's a free program. They will offer NRTs, which is the patches, the gum. They'll send those to your house. They'll make that available to you so that you can relieve some of those physical symptoms. It's a truly wonderful program. They're available 24/7. All of their staff is trained in helping folks quit. and it can really help you prevent a lot of the cancers and the other health conditions that come with smoking.
If you have questions for Danielle Campbell, text me at 248-935-2562 or submit on Facebook or YouTube if you are watching there. The first question that's come in is vaping as harmful to the lungs as cigarette smoking?
That's a great question. There is so many studies being done on vaping, and there's some inconclusive answers regarding what is worse. There's so many long-term studies done on cigarette smoking. It is by far and wide, I would definitely say, something you should try to avoid doing. Anything that you're inhaling into your lungs that is not fresh air is probably not a great idea, so we would never recommend vaping as an alternative to smoking. I would never recommend vaping as something to use to quit smoking. It is not something that I would recommend using. It's not a product that I would say is better. It's just different products.
Do you have to quit cold turkey, or can you step down, go from half a pack a day to 2 cigarettes a day?
Yeah, that's also a great question. There's a variety of ways to quit. So some people quit cold turkey very successfully. That's probably the hardest way to do it, but many people do. Others can do kind of a taper down. You know, you're at a pack a day to half a pack a day to less than that. And that's another very appropriate way to do it. And it can just depend on you, your lifestyle, how long you've smoked, what products you smoke, your patterns in doing it. So some people will shorten the amount of time a day that they smoke. Many folks just take so many different approaches, and truly, if the end result is you quitting, there was no incorrect way to do it.
Isn't nicotine patch cheating? You're replacing one addiction with another.
It's actually not cheating. It's the same substance. The great thing about the nicotine replacement therapy is that it only gives you the nicotine, which is kind of that addictive substance, but it leaves out all of the other bad parts that come from the cigarette. So all of the tar, all of the poisonous carcinogens that are inside of it. You're not getting any of that. You're only getting just that nicotine. And the patch does come in a step-down level. So as you put the patch on, it's not as much nicotine as you get when you're smoking. And then as you have that on, you'll lower your dosage. And as time goes on, you're getting less nicotine. Your physical addiction is reducing. And then you can wean yourself kind of off of that. So I wouldn't call it replacing it. I would call it a focused nicotine effort to reduce.
You've helped a lot of people in the past, and you talked about like the car and how it's like a habit to smoke during the car. Do you have some tricks, like should people suck suckers or chew on a straw? Or
For the car specifically? Yes.
Or, what are some of your tricks that you can tell people?
Sure. For the car specifically, anything you can do to kind of change what you're doing is helpful. Some people will take a different route to work. So you're actually physically and mentally having to think about where you're driving versus it being kind of automatic. Other people sing along to the radio. They will chew on a toothpick, suck on a straw. Some people will, have hard candy. There's a variety of methods that can work for people. I wouldn't replace it with a vaping device or other options like that, but to keep yourself busy, even a fidget spinner or something that you can do with your hands or mouth to keep yourself busy.
And how long do you think it takes to kick a habit?
So that's also a great question. Once again, completely depends on the person. If you've smoked for a longer time, many people find that to be more difficult to quit. But that's not the case for everybody. Some people can wake up and just quit. Others, it takes them, 2 weeks, 6 months, a year. My best recommendation is to pick a date for yourself. Try to keep that date separate from big events. Keep it away from holidays, birthdays, anniversaries. Make it its own very special date. And try to make that date within a month's time. And that gives you time to prepare and plan. It also gives you time to reduce your dosage, reduce your smoking, change your habits, really put a focused effort on your quit process. And then once you hit that month timeline, you can kind of hopefully be done. Try not to do it too long.
That's great, Danielle, because you're actually giving people a game plan, gives them a goal to set. Thank you, everybody, for joining us today. Contact our experts if you want to move forward with lung screenings or smoking help. You can go to hurleymc.com. We hope you join us next month as we bring you a live healthy living workshop on uterine fibroids and pelvic health. Have a great day, everyone.